Like the lecture last week, this week's lecture will meet the course objectives by first identifying prevalent communicable diseases and their current epidemiology and routes of transmission in Canada. Secondly, recognizing their control and prevention by current public health policies, practices, or regulations. Thirdly, recognizing relevant laboratory techniques and tests used to culture, identify, and classify human pathogens and relevant terms encountered in reports or in the literature. And finally, understanding the major mechanisms used by microbial pathogens to cause disease. This week, we will look at communicable enteric food and waterborne diseases in Canada, which are campylobacteriosis, salmonellosis, shigellosis, virotoxigenic E. coli infection, hepatitis A, and norovirus infection. We'll also be able to recognize the clinical features of these diseases and comprehend their pathogenesis, as well as identify the transmission routes and epidemiology of these diseases, recognize laboratory methods used to confirm their diagnosis, and recognize how the transmission of these diseases can be controlled and prevented. Of the viral diseases and infections that are food and waterborne, norovirus infection has a high incidence rate due to the large number of outbreaks that are reported every year. If we had more time, I would have included polio, but we've already covered a very long list of communicable diseases, and since there is no local transmission of this disease in Canada, I'll be skipping it this year. This table lists all the bacterial diseases we'll be covering today. Campylobacteriosis tops the list as the disease in this group that has the highest incidence rate. Then salmonellosis, whereas shigellosis and virotoxigenic E. coli infections both have the lowest incidence rates of this group of diseases. I've added typhoid to the list to indicate that it is a different disease to salmonellosis, although we won't have time to learn about this disease. The clinical symptoms for hepatitis A appear abruptly, usually around 30 days after exposure. These include fever, nausea, stomach discomfort, general malaise, dark urine, and jaundice, that is the yellowing of skin and eyes, in adults and school-aged children. The illness is usually most severe with increasing age, and many younger children have few symptoms and no jaundice. Most cases of mild to serious hepatitis A recover naturally in just over a month. However, about a quarter of adult cases may need hospital care. Although symptoms can recur for up to a year, in a small number of cases, chronic infection does not occur. Unlike hepatitis B and C, hepatitis A is more benign and does not lead to persistent liver inflammation, cirrhosis, or scarring of the liver or liver cancer. Individuals with pre-existing chronic liver disease are at increased risk of serious complications from hepatitis A. Fulminant disease with liver necrosis can be fatal. However, death from hepatitis A virus infections is rare, and a very low case fatality ratio of 0.2% is usually observed. This rises to 1.8% in persons older than 50 years of age, to 12.5% in patients older than 60 years who need to be treated in hospital. Lifelong immunity usually follows infection. Hepatitis A can be transmitted 1 to 2 weeks before symptoms appear, till the first week after jaundice occurs. Unlike hepatitis B and C, infected individuals do not carry the virus permanently. Humans are the principal reservoir, but non-human primates, for example monkeys, may also be infected. The virus may persist for days or weeks in the environment. The route of transmission is fecal-oral, through eating contaminated food, such as raw shellfish and vegetables, or drinking contaminated water. It is rarely transmitted through contaminated blood. Major risk factors are being household contacts of an acute case, and transmission can occur through direct person-to-person contact, including sexual contact. Sexual behaviors involving anal contact is also a major risk factor, and major outbreaks have occurred in the men who have sex with men community. Residents in rural or remote areas that lack adequate sanitation or a secure supply of potable water is also a risk factor. As well, residents in correctional facilities and those for developmentally challenged individuals also increases risk of getting hepatitis A. Risk of getting hepatitis A is seldom related to contaminated injection material, but more usually associated with low hygiene standards, contaminated drugs, and sharing of materials for oral or nasal use of drugs. Travel to or residence in countries where hepatitis A is endemic is also a risk factor. 40% of all notified hepatitis A cases have been in travelers. Of these, 40% are taking low-risk trips, staying for short periods of time in luxury hotels where meals are provided. Every year, more than 5 million Canadians travel to a hepatitis A endemic country. At risk are also new immigrants or children of new Canadians who return to their country of origin to visit friends and relatives. In spite of outbreak investigations, more than a quarter of cases have no identifiable risk factor. Although hepatitis A outbreaks are associated with infected food handlers, these individuals are not at a higher risk of being infected with hepatitis A because of their occupation. However, they may be more likely to belong to a demographic group with a higher incidence of hepatitis A and thus may be the source of major foodborne outbreaks. These outbreaks may trigger very extensive public health interventions that become necessary when a food handler is found to be contagious, even if the number of secondary cases is ultimately small. Hepatitis A occurs worldwide and is commonly reported where public sanitation is poor. There are around 1.5 million cases each year, and the global prevalence is between a low of 15% to a high of 100% in various parts of the world. The Canadian hepatitis A incidence rates in the past 10 years range from 0.5 to 1 case per 100,000 population, which corresponded to 180 to just over 380 cases per year. The Ontario rates were similar, ranging from 0.5 to 1.5 cases per 100,000, corresponding to 70 to 220 cases per year. It's the Toronto rates that are different and higher than the national and provincial rates, ranging from 0.9 to 2.2, corresponding to 25 to 63 cases per year. It is estimated that actual case numbers are roughly 7 times greater than reported due to asymptomatic infections, underdiagnosis, and underreporting. Outbreaks associated with men who have sex with men have been reported in major Canadian cities, including Toronto, with 25 confirmed and probable cases from January 2017 to November 2018. Cases had a mean age of 38 years, and mapping located the cluster in downtown Toronto. Other recent outbreaks and alerts have either been associated with contaminated food or secondary spread from a travel-related index case. The most recent report was from Simcoe Muskoka District Health Unit, with a cluster of 30 cases associated with secondary spread from an index case that was likely a returning traveler. Other reports are alerts after hepatitis A infected food handlers were identified at various locations in Toronto. Based on the dates of exposure, any consumers of food and drinks at these locations were advised to attend the free publicly funded hepatitis A vaccine clinic and also monitor for symptoms. In April 2016, an outbreak associated with contaminated frozen fruit occurred. 19 of the 25 cases were in Ontario. A systematic review of all Canadian seroprevalence studies showed that seroprevalence increased with age and was at 1% in unvaccinated Canadian-born children with no travel history to endemic countries, and 20% of unvaccinated Canadian-born adults had antibodies. This is likely due to both cumulative incidence with increasing age and a cohort effect attributable to higher incidence rates of this disease in the past. A case of hepatitis A is confirmed in the laboratory by the detection of immunoglobulin M antibody to the hepatitis A virus, an acute clinical illness characterized by discrete onset of symptoms, including fever, malaise, anorexia, nausea, and abdominal pain, followed by jaundice or elevated aminotransferase levels within a few days. Another criterion that may be used as an alternative to laboratory testing is epidemiologic linkage to a lab-confirmed case. Clinical specimens that need to be collected for laboratory diagnosis is blood or serum. Serological testing using immunoassays such as ELISAs are used to detect IgM antibodies to the hepatitis A virus. Hepatitis A is caused by the hepatitis A virus, which is in the picornaviridae family, or the picoRNAviridae family. So viruses that belong to this family are very small, and the hepatitis A virus is only 27 nanometers in diameter with cubic symmetry. In comparison, the chickenpox virus is nearly 10 times larger at 200 nanometers. The hepatitis A virus belongs to the hepatovirus genus and is a naked, single-stranded, positive strand RNA virus. There is only one serotype, but there are a few different genotypes. In terms of pathogenesis, the hepatitis A virus replicates initially in the intestinal mucosa before spreading to the liver, where there is further replication causing lymphoid cell infiltrates, proliferation of Kupffer cells, which are liver macrophages, and eventually necrosis of liver cells. There is currently no effective therapy, and most cases recover after about a month. Transmission can be prevented by good hand hygiene, especially in food handlers, immunization of travelers, and high-risk groups using the vaccine for hepatitis A alone or the combination vaccine with hepatitis B. Recovery results in protective, lifelong immunity. Workers in occupational groups who should be vaccinated include military personnel and humanitarian relief workers who are posted in areas where hepatitis A is endemic. Also, zookeepers, vets, and researchers who handle non-human primates, and laboratory workers who are handling the hepatitis A virus in research or vaccine production should be immunized. Post-exposure prophylaxis, including the provision of immunoglobulins to susceptible individuals, should be offered to household and sexual contacts of people infected with hepatitis A, contacts in group child care centers and kindergartens, and co-workers and clients of infected food handlers. Hepatitis A vaccines, which contain the inactivated hepatitis A virus, are available in pediatric and adult formulations, as well as in combination with the recombinant hepatitis B surface antigen or the typhoid purified capsular polysaccharide. The next virus that we'll look at is norovirus, which used to be called the Norwalk virus just over 20 years ago, when this virus caused the first outbreak in a school in Norwalk, Ohio. This information is also on a slide later on in the presentation. Once infected, there is a short incubation period of 2 days, after which nausea, vomiting, diarrhea, and stomach cramps present, and there may also be low-grade fever, chills, headache, muscle aches, and fatigue in some cases. So sometimes it is referred to as stomach flu, although this condition may also be caused by other pathogens, and laboratory confirmation is required. The acute diarrhea and vomiting does not continue for long, usually lasting around less than half a day in healthy individuals, with recovery occurring after 2 days. However, the very young and the elderly, and those who are immunocompromised, may suffer most severe illness, and dehydration can be a problem, especially in young babies. Transmission from infected individuals is during the period of illness, as well as from 3 days to sometimes 2 weeks after recovery. So it's important to ensure that recovered cases maintain good hand hygiene, as the main route of transmission is via the fecal-oral route, either through contact with feces or vomitus from infected individuals. Norovirus infections can also be transmitted by either direct contact with those who are ill or indirect contact with fomites, such as contaminated surfaces, door handles, or consumption of contaminated food or water. Norovirus is very hardy and survives relatively high levels of chlorine, varying temperatures, and can remain viable on hard surfaces for up to 12 hours. The virus is easily transmitted in environments where people are in close contact, including schools and daycare centers, long-term care facilities, healthcare facilities, and cruise ships. As I mentioned previously, the first outbreak of norovirus was identified in Norwalk, Ohio, nearly 50 years ago. In Canada, although norovirus infections became a national notifiable disease in 2007, only outbreaks are reported by most provinces and territories. There are around 300 to 400 outbreaks a year in Canada. This has increased considerably from less than 100 outbreaks before 2001. The increase is likely due partly to increased numbers of outbreaks, as well as improved awareness and reporting of norovirus outbreaks. One of the last annual reports published by Toronto Public Health showed that there were 278 outbreaks in 4 years in Toronto, with around 50 outbreaks a year. Nearly half of the reported enteric outbreaks in Toronto were caused by norovirus, making it the most frequent identified etiological agent, mainly in long-term care homes and child care centers. Recent outbreaks include one in May 2019 in 2 different Vancouver airport hotels, with more than 100 cases. There was another in 2018, also in British Columbia, linked to contaminated raw oysters from Vancouver Island. In 2017, there was an outbreak in Humber College, but the source was not identified. And from late 2016 to mid-2017, there was another massive outbreak associated with sewage-contaminated BC oysters. Since it's mainly outbreaks that are reportable, a case of norovirus infection is defined as 2 or more cases of clinical illness compatible with norovirus that can be epidemiologically linked to one another, at least one of which is laboratory confirmed. A community outbreak is defined as 2 or more unrelated cases of illness compatible with norovirus that can be epidemiologically linked to one another, and an institutional outbreak, 2 or more cases of clinical illness compatible with norovirus that are epidemiologically linked in an institutional setting. As mentioned on a previous slide, the Norwalk virus was given the new name norovirus in 2002. It belongs to the Calliciviridae family and is in the genus with the same name. It is a small, cubic, naked, single-stranded positive strand RNA virus. There are 4 different serotypes and 5 different genogroups. The majority of outbreaks are caused by viruses belonging to genogroup 2 with the genotype 4. This diagram shows the 5 different genogroups of noroviruses based on their capsid protein sequences. Within each genogroup are the different genotypes. Genogroup 2 has viruses isolated from both human and swine. Clinical specimens that should be submitted are stools and vomitus. Norovirus infections are confirmed by laboratory diagnosis using reverse transcription PCR, since the virus cannot be cultured in vitro currently. The difficulty in propagating them has hampered further understanding of their pathogenesis. The virus infects the small intestine by attaching to blood group antigens such as the A, B, and O types. So far, no enterotoxins have been identified. The immune response to norovirus is complex and poorly understood, and infections with G24 variants do not provide acquired immunity, indicating that they have evolved to escape from neutralizing antibodies. There is currently no treatment for norovirus infections, so supportive measures need to be provided for the very young and elderly to prevent dehydration, which if serious needs to be managed in hospital. No vaccines are available at present, so prevention is through good hand hygiene, especially after using the washroom or changing diapers, and before eating or preparing food, especially after recent illness or contact with an ill person. One really important note on prevention of norovirus infections is the controversial efficacy of alcohol-based hand sanitizers, since it is a naked virus. Washing with soap and water is considered to be more effective and is recommended. To prevent further transmission, especially in an outbreak situation, thorough cleaning of contaminated surfaces immediately after an episode of illness with hot, soapy water, and then disinfection of the area using bleach needs to be carried out. Soiled clothing and linens need to be removed and washed, and gloves should be worn when handling soiled materials. Infected individuals should be either excluded or isolated from others, especially in residential or congregate settings, such as long-term care facilities, acute care hospitals, cruise ships, and college dormitories, as these have been shown to be the most practical and effective means of interrupting transmission of the virus and limiting contamination of the environment.